Welcome to the deep dive.
Great to be here.
If you're looking for a smart way to really get your head around essential medical topics, you're definitely in the right place.
Mm-hmm.
Today, we're diving into chronic pancreatitis. We've got some pretty detailed notes, and we're going to pull out the absolute must-knows.
Exactly. Think of it as your fast track.
Yeah, building a solid foundation on this condition is pretty important.
It really is. Our goal isn't to drown you in detail, but to, extract those key nuggets.
It's knowledge.
Precisely. What it is, the causes, risks, how it works, diagnosis, management, outlook, all the crucial bits.
Perfect. All right, let's jump straight in then.
Yeah.
Chronic pancreatitis. What's the core definition we need to hold on to?
Okay, so in simple terms, it's long-term inflammation of the pancreas,
Long-term meaning.
meaning it leads to permanent irreversible damage.
Mm-hmm.
And this damage hits both main jobs of the pancreas.
Both jobs.
Yeah, the exocrine side that's making digestive enzymes, and the endocrine side, which handles hormones, like insulin.
Ah, okay. So it really messes with digestion and blood sugar control. A double whammy.
That's a good way to put it. It disrupts quite a lot.
And is there one main cause we should immediately think of?
Definitely. Think A for alcohol. Excessive chronic alcohol consumption is the big one. Responsible for maybe 80% of cases.
80%? Wow.
Yeah. And beyond the cause, it's known for causing really severe abdominal pain.
Right.
And honestly, it can be frustratingly difficult to diagnose and manage. Patients often face delays in getting answers.
That sounds tough. Now, the notes mention different types, large duct and small duct pancreatitis. What's the key difference there for us?
Good question. Okay, a simple way to think about it. Large often goes with male and calcification.
Okay.
So large duct type typically shows widened pancreatic ducts that don't function well, and you often see calcium deposits, calcifications. More common in men.
Got it. And small duct?
Small duct. Think sensitive to enzymes and maybe more common in women. Imaging might actually look normal.
Oh, really?
Yeah, which makes it trickier sometimes. It's seen more in women. And the interesting thing is sometimes just giving pancreatic enzyme supplements can significantly help with symptoms.
That's a useful distinction. What about those other specific types mentioned, like hereditary and tropical? Any key flags for those?
Sure. For hereditary pancreatitis, the keywords are genes and greater cancer risk.
Okay, genetic link.
Exactly.
Huh.
It's caused by specific gene mutations, like the PRSS1 gene is a classic example. And importantly, it increases the risk of developing pancreatic cancer down the line.
Right, that's crucial. And tropical.
Tropical chronic pancreatitis, think stones and sugar issues, primarily in developing countries. It's associated with calculi, or stones, forming in the pancreas.
Pancreatic stones, okay.
And it often leads to diabetes that requires insulin.
And the last one was autoimmune pancreatitis. Sounds like the body attacking itself.
That's exactly what it is. The immune system mistakenly targets the pancreas.
Is there any upside there?
Well, the potential upside is that it might respond well to steroid treatment. But the flip side is there's also a possible increased risk of pancreatic cancer, similar to hereditary. We often talk about two types here, AACP or type 1,
Okay.
which is actually more common in places like Japan. And then there's IDCP, type 2.
Got it. Now let's contrast this with acute pancreatitis. People hear pancreatitis and might mix them up. They both involve inflammation, right?
They do, and that's a really critical distinction to make. Just clear in your mind.
Okay.
Acute pancreatitis is inflammation, but usually the pancreas recovers. The damage is typically reversible.
Right, temporary damage.
Exactly. Chronic pancreatitis, however, involves that irreversible damage we've been discussing, that scarring, that fibrosis.
So permanent change.
Permanent changes.
Yeah.
And what's tricky is that spotting chronic pancreatitis early, well, it can be hard. Those calcifications we mentioned.
Yeah.
They might take years, literally years, to become visible on scans after someone actually starts having symptoms.
Wow, so someone could be suffering for a long time before it's obvious on imaging.
Precisely, which adds to the diagnostic challenge.
Okay, definition covered. Let's nail down the why, the etiology. What are the main causes again?
So circling back, number one, without a doubt, chronic alcohol abuse.
Right.
But don't stop there. Think GAO, G for genes, A for autoimmune, and O for obstruction.
Obstruction like?
Like a blockage in the pancreatic ducts. Could be from a tumor, maybe gallstones causing problems, that sort of thing.
And those subtypes we just discussed, like hereditary, they tie directly back to these causes, don't they?
Absolutely. It reinforces those links. Understanding the underlying cause helps categorize the condition and think about the specific pathways involved.
Makes sense. Okay, moving on to who's more likely to get this. What are the key risk factors?
Well, the risk factors really echo the causes quite closely.
Okay.
So heavy chronic alcohol consumption is top of the list. Smoking is a big one too. And remember, it's considered an independent risk factor.
Meaning even without heavy drinking, smoking alone increases risk.
That's right. Then you have genetic predisposition if it runs in the family.
So family history matters.
Definitely. A family history of pancreatitis.
Mhm.
Also, gallstones can be a risk factor, and high levels of triglycerides in the blood, hypertriglyceridemia.
The notes also mention predisposing factors. Is that just another term for risk factors, or is there a nuance?
They're very closely related, almost interchangeable here, but predisposing factors maybe adds a bit more context.
Right.
Like the statistic that in Western countries, something like 60 to 70% of chronic pancreatitis patients have that history of significant alcohol abuse.
That's a stark number.
It is. And genetically, specific gene abnormalities, like in GGT1, CFTR, the cystic fibrosis gene, and SUSIBK1, can predispose someone.
CFTR, so a link to cystic fibrosis.
Well, mutations in that gene, yes. It highlights that it's often multifactorial. It's rarely just one single thing. It's a complex interplay of genes, environment, lifestyle, metabolic changes.
Right, a combination of hits, maybe.
Sort of, yeah.
So what's actually going on inside the pancreas at the cell level, the pathophysiology? How does this damage happen?
Okay, the core mechanism is this cycle of repeated inflammation. This leads to injury, cell death, and then the body tries to repair it, but does so by laying down scar tissue. That's fibrosis.
Scarring instead of healthy tissue?
Exactly.
Yeah.
This fibrosis replaces the functional pancreatic tissue, which is why the pancreas stops working properly over time.
And that affects both the digestion and hormone functions we talked about.
Precisely. You reduce secretion of digestive enzymes, that's the exocrine failure, leading to malabsorption of nutrients.
Right. Food isn't broken down properly.
Correct. And at the microscopic level, several things are happening. You've got obstruction of the small ducts within the pancreas.
Okay.
You have pancreatic enzymes activating inside the pancreas itself when they should only be active in the gut. That causes autodigestion and damage.
Ouch.
Yeah. Plus, there are epigenetic changes, alterations in how genes are expressed, the direct toxic effects of alcohol metabolites, and increased oxidative stress. Think of it like cellular rust.
All contributing to that fibrosis.
Exactly. They all feed into this process of scarring and loss of function.
With symptoms like severe pain and weight loss, it sounds like it could be mistaken for other things. What's on the differential diagnosis list? What else do doctors need to consider?
Absolutely. This is crucial. You need a broad perspective. Think about other causes of abdominal pain.
Like
Gallbladder inflammation, acute cholecystitis, peptic ulcer disease, liver inflammation, acute hepatitis, even something really serious like an abdominal aortic aneurysm.
okay, vascular causes too.
Yes. Kidney infections, pyelonephritis, can sometimes present with upper abdominal pain. And of course, you need to rule out acute pancreatitis.
Makes sense. Anything else?
Interestingly, sometimes the cause isn't even in the abdomen. A heart attack, myocardial infarction, or pneumonia can occasionally refer pain that feels like it's in the upper abdomen.
Wow, okay. So, keep a wide net. What if imaging does show calcification in the pancreas? Is that always chronic pancreatitis?
It's a very strong sign, but not absolutely pathognomonic. You should also consider a few other possibilities for pancreatic calcification.
Such as?
Severe protein malnutrition can sometimes lead to it. Hereditary pancreatitis, which is a type of chronic pancreatitis, often features calcification. And also hyperparathyroidism, an overactive parathyroid gland problem that messes with calcium levels.
Right, affecting calcium everywhere. Okay, let's shift to how common this is. What's the epidemiology in the UK?
In the UK, we're looking at roughly 25 to 50 cases per 100,000 people.
And is that number stable?
Unfortunately, the rates seem to be rising.
Any demographic trends?
Yeah, it's definitely more common in males than females. The ratio is about 4 to 1 male to female.
4 times more common in men.
Roughly, yes.
Yep.
And the typical age of onset is usually between 30 and 40 years old.
So often hitting people relatively young in their working years.
Exactly. Middle age, often.
Now, presentation. How does someone with chronic pancreatitis typically show up? What are the key clinical features?
The hallmark, the classic symptom, is persistent upper abdominal pain, often described as quite severe, maybe boring through to the back.
Severe pain first.
Yes. Along with that, nausea, vomiting, and unintentional weight loss are very common.
Weight loss due to?
Multiple factors: pain-reducing appetite, fear of eating because it triggers pain, and actual malabsorption.
Right.
As the disease progresses, you often see steatorrhea develop.
Steatorrhea, that's the fatty stools.
That's right. Pale, bulky, foul-smelling, difficult to flush stools. It's a sign the pancreas isn't producing enough enzymes to digest fat. And then later on, diabetes mellitus can develop as the insulin-producing cells get damaged.
Is there a typical timeline for these symptoms appearing?
There often is, though it varies. The pain usually comes first. It characteristically worsens maybe 15 to 30 minutes after eating.
Ah, postprandial pain.
Exactly. Steatorrhea tends to appear quite a bit later, sometimes 5, 10, even up to 25 years after the pain starts.
That's a huge lag time.
It is, and diabetes often develops even later than that, sometimes more than 20 years after the initial symptoms began.
Wow. So the pancreas function declines very gradually over decades.
In many cases, yes, it's a slow, progressive destruction.
What else should we know about how it manifests? Is the pain always constant?
Not always. The pain can be tricky. It might be episodic, coming in flares that last days or weeks, or it can become a continuous background pain.
And generally severe.
Often severe enough that patients require opiate pain relief, which brings its own challenges.
Sure. Dependence and side effects.
Right. Other associated symptoms include decreased appetite, the malabsorption leading to weight loss and sometimes diarrhea, and even signs of protein deficiency like muscle wasting or swelling.
And on examination, anything specific to find?
Physical examination might be relatively normal, especially early on, but often there's tenderness when pressing on the upper abdomen.
Okay. So given this variable presentation and long timeline, how do doctors actually investigate and confirm a diagnosis?
It requires putting several pieces together. It's a combination of clinical suspicion, imaging, and function tests.
So blood tests first.
Usually, yes. Basic bloods like a full blood count, urea and electrolytes, creatinine, liver function tests. Checking calcium and glucose levels is important. HbA1c gives a picture of blood sugar control over time.
What about pancreatic enzymes like amylase and lipase?
They are checked, but here's a key point. In chronic pancreatitis, amylase and lipase may actually be normal or only slightly elevated, unlike in acute pancreatitis where they're typically very high.
Ah, okay, so normal enzyme levels don't rule it out.
Exactly. Don't be falsely reassured by normal enzymes if the clinical picture fits. Imaging becomes really crucial.
What kind of imaging?
CT scan is often the first-line investigation. It can show calcifications, duct dilation, atrophy of the pancreas. MRI is also very useful, especially MRCP,
MRTP.
magnetic resonance, cholangiopancreatography. It gives detailed pictures of the bile ducts and pancreatic ducts. Sometimes a secret and enhanced MRI is done to assess duct function.
And endoscopic ultrasound, EUS.
EUS is very sensitive for picking up subtle changes of chronic pancreatitis, like changes in the pancreas texture or small duct abnormalities, even before CT or MRI show obvious signs.
So EUS is quite important for early detection.
It can be, yes. Very useful.
What about testing the function directly? I remember you mentioned enzyme issues.
Right. The fecal elastase test is a common way to assess exocrine function. You measure the level of elastase, a pancreatic enzyme, in a stool sample. Low levels indicate pancreatic insufficiency.
Simple stool test, okay.
There's also the secretin stimulation test, which is more involved but considered a gold standard by some. It directly measures the pancreas' ability to produce bicarbonate after stimulation.
And ERCP, is that just for diagnosis?
ERCP, endoscopic retrograde cholangiopancreatography, gives very detailed images of the ducts and allows for interventions like removing stones or placing stents in narrow ducts. It's more invasive, so it's often reserved for when therapy is planned, but it can be diagnostic too.
Any other tests? Nutritional markers?
Yeah, checking things like magnesium, albumin levels, and maybe specific vitamin levels can give insight into nutritional status, which is often compromised. And HbA1c tracks diabetes development.
Can you biopsy the pancreas?
You can, but it's rarely done just for diagnosis because it carries risks, like bleeding or triggering acute pancreatitis. Usually the diagnosis is made based on the clinical picture, imaging, and function tests. Biopsy might show inflammation and fibrosis, but it's often not needed.
So piecing together that puzzle, as you said, it highlights the challenge, especially early on, with no single perfect test.
That's the key challenge, definitely. Lack of specific early biochemical markers.
Okay, once the diagnosis is made, what's the management strategy? How do you help these patients?
Management is really multifaceted. It focuses on 3 core pillars: controlling pain, managing the exocrine and endocrine insufficiency, malabsorption and diabetes, and addressing underlying causes and lifestyle factors.
Let's start with pain. It sounds like a major issue.
It absolutely is often the most debilitating symptom. The approach is usually stepwise. Start with simple analgesics like paracetamol, maybe NSAIDs if appropriate, but often patients need stronger medications.
Like opioids.
Yes, often progressing to weak opioids like codeine or tramadol, and then potentially strong opioids like morphine or fentanyl patches for severe chronic pain. Though obviously you have to be careful about dependence and side effects.
Are there non-medication options for pain?
Yes, interestingly, taking pancreatic enzyme supplements, P or POR, with meals can sometimes reduce pain, possibly by reducing pancreatic stimulation.
Oh, that's interesting. Enzymes for pain relief.
You can help some patients. If there are specific structural problems like narrow ducts, strictures, or stones blocking the ducts, then ERCP can be used therapeutically to dilate strictures or remove stones.
Okay, endoscopic treatment.
Exactly. For some patients with intractable pain, a celiac plexus block might be considered. It involves injecting anesthetic or neurolytic agents near the nerves that transmit pain from the pancreas.
Is that permanent?
Usually temporary relief, lasting weeks to months. And then for very severe persistent pain that doesn't respond to other measures, surgery might be an option.
Surgery? What kind?
It depends on the problem. If there are stones or strictures causing duct obstruction that can't be fixed endoscopically, surgical decompression might be done. Sometimes, resection removing part of the pancreas is considered, like a Whipple procedure, pancreatoduodenectomy, though that's major surgery.
Right. Okay, second pillar, managing malabsorption and nutrition.
This is vital. The cornerstone here is pancreatic enzyme replacement therapy, PIRITA.
Like Creon.
Creon is a common brand name, yes. These capsules contain the digestive enzymes the patient's pancreas isn't making enough of. They need to be taken with meals and snacks.
To help digest the food?
Precisely, especially fats. Getting the dosing right can take some trial and error. Dietary advice is also key.
What kind of diet?
Typically, advice focuses on maintaining adequate calorie and protein intake.
Yeah.
Historically, very low-fat diets were recommended, but now the focus is more on adequate PERT dosing to allow for a more normal fat intake, which improves nutrition and quality of life. High protein is often encouraged. Small, frequent meals might be better tolerated than large ones.
And managing the diabetes if it develops.
Yes, that requires standard diabetes management, often including insulin therapy, as oral medications might not be sufficient when the insulin-producing cells are destroyed.
Okay, and the third pillar, lifestyle.
Absolutely crucial. Addressing the underlying cause if possible. The most important things are complete abstinence from alcohol.
Complete abstinence, not just cutting back.
For chronic pancreatitis, complete abstinence is strongly advised, as even small amounts can potentially trigger pain and further damage. Stopping smoking is equally important.
Because smoking is an independent risk factor.
Exactly. So supporting patients with alcohol and smoking cessation is paramount. Dietary changes we discussed. And managing potential opiate dependence carefully is also part of it.
You mentioned surgery again for pain. Can we elaborate a bit more on those surgical options?
Sure. Endoscopic ultrasound, EUS, isn't just diagnostic. It can be used therapeutically too, for example, to drain pseudocysts or guide nerve blocks. ERCP, as we said, for stones and strictures. If ERCP fails or isn't suitable for ductal obstruction, surgical drainage procedures, like connecting the pancreatic duct to the intestine, Poisteau or Frey procedure, might be done.
To bypass the blockage.
Essentially, yes. And pancreatic resection, like the Whipple or sometimes a distal pancreatectomy, removing the tail of the pancreas, is considered for severe pain, especially if the disease is localized to one part of the pancreas. But these are big operations with significant risks.
Are there any newer approaches being explored?
Yes, there are some interesting developments. One is total pancreatectomy with autologous islet cell transplantation.
Oh, break that down.
Okay, so you remove the entire pancreas, which cures the pain but causes severe diabetes. But before removing it, you isolate the patient's own insulin-producing islet cells.
Their own cells?
Yes, and then transplant those cells back into the patient, usually into the liver. The hope is these cells will engraft and produce enough insulin to prevent or lessen the severity of diabetes.
Fascinating. Anything else?
There's ongoing research into other pain management techniques, like radiofrequency ablation of nerves or even spinal cord stimulation for refractory chronic pain.
Lots of options, but clearly complex management. So what's the overall outlook, the prognosis for someone with chronic pancreatitis?
It's quite variable. Honestly, it really depends on the underlying cause, the severity of the damage, the presence of complications, and importantly, the patient's lifestyle choices moving forward.
Like stopping alcohol and smoking.
Exactly. Early diagnosis and comprehensive management, including those lifestyle changes, definitely lead to better outcomes. But it is a serious condition.
Associated with increased mortality.
Yes, unfortunately. Chronic pancreatitis is associated with increased morbidity and mortality compared to the general population. Factors linked to a poor prognosis include continued smoking, ongoing alcohol intake, and the development of complications like end-stage liver disease or pancreatic cancer.
Are there any survival statistics?
The figures vary, but generally the 10-year survival rate after diagnosis is around 70%, and this drops to maybe 45% at 20 years.
So a significant impact on lifespan.
A significant impact, yes.
And what kinds of complications can arise directly from the chronic pancreatitis itself?
There's a fair list. Pancreatic pseudocysts are quite common. These are collections of fluid that can form near the pancreas.
Do they need treatment?
They might if they cause symptoms like pain, get infected, or press on nearby organs. Drainage, often endoscopically via EUS, might be needed.
Okay, what else?
Malnutrition and weight loss are almost inherent complications due to the malabsorption. Diabetes mellitus, as we've discussed, often develops eventually, bringing its own set of potential long-term complications.
And the cancer risk.
Yes, there's a significantly increased risk of developing pancreatic cancer, particularly long-term. The chronic inflammation is thought to be the driver.
That's a major concern.
Absolutely. Duct obstruction can worsen things. Pancreatic insufficiency, the severe lack of enzymes, exacerbates the malabsorption. You can also see deficiencies in fat-soluble vitamins and sometimes cobalamin or vitamin B12 deficiency.
Yeah.
Less commonly, things like fluid around the lungs, pleural effusions, or bleeding in the gut can occur.
Okay, quite a range of potential problems stemming from this.
It really affects multiple systems.
This has been incredibly thorough. We've really unpacked chronic pancreatitis. It's clear it's a complex, challenging condition with far-reaching effects. To try and summarize, what are the absolute key takeaways for our listeners?
Okay, key takeaways. Remember, it's long-term, irreversible pancreatic inflammation and damage.
Irreversible being key.
Crucial. Strongly linked to chronic alcohol excess, but also genetics, autoimmune issues, obstructions. Smoking is a big independent risk factor.
Right.
It impacts both digestion, exocrine causing malabsorption, stearia, and hormone production, endocrine leading to diabetes. Severe pain is characteristic.
Pain, malabsorption, diabetes.
Exactly. Diagnosis can be tricky, often relying on imaging, CT, MRI, US, and function tests, fecal elastase, as blood enzymes might be normal.
Management is multi-pronged.
Yes. Pain control, often needing opioids, enzyme replacement, P-E-R-T, managing diabetes, and absolute alcohol smoking cessation. The prognosis varies, but it does reduce life expectancy and carries risks like pancreatic cancer. Early intervention and lifestyle changes are vital.
That's a brilliant summary. Hits all the high points. And just as a final thought to leave people with, perhaps something to mull over is the evolving understanding of that interplay between genes and environment. We're still learning exactly why some heavy drinkers get this and others don't, right?
Absolutely. That genetic susceptibility interacting with environmental triggers like alcohol or smoking is a huge area of ongoing research. It's not just one thing.
Food for thought indeed. Now, if you listening want to really solidify this knowledge and tackle other key medical topics for exams like the MSRA or just for your own learning,
You should definitely check out pastthemsra.com.
yes, pastthemsra.com, and there's also freemsra.com for great free resources too.
Highly recommended. Packed with high-yield information.
Perfect. Well, thank you so much for guiding us through that complex topic.
My pleasure.
And thank you all for joining us on the deep dive.